Okay, why don't we continue a short discussion by showing a few more cases of muscle abnormalities. Again, this is not a organized, complete description, but to go over a few things for you to kind of remember in the back of your minds. So this.
Do you have a meeting number to give him?
Is he asking for one?
Yeah, maybe he's being prompted for one.
Let's see here. Okay, why don't we continue a short discussion by showing a few more cases of muscle abnormalities. Again, this is not a organized, complete description, but to go over a few things for you to kind of remember in the back of your minds.
Do you have a meeting number to give him?
Is he asking for one?
Yeah, maybe he's being prompted for one.
Let's see here. Okay, why don't we continue a short discussion by showing a few more cases of muscle abnormalities. Again, this is not a organized, complete description, but to go over a few things for you to kind of remember in the back of your minds. So this is some more teaching material from Dr. Seuss from South Korea. So, Tayson, what do you think of this patient with 67-year-old male with sudden onset pain and swelling of the right forearm?
There's definitely an increased signal on the sequences there, and also maybe some enhancement. Not sure if that's real.
Yeah, we don't really have a T1 pre, so it's a little hard to interpret this, but maybe there's some spotty enhancement there.
Yeah, some sort of myositis. Oh, acute compartments.
Yeah, this is a acute compartment syndrome. So you can think of myositis, but what we have is swelling within a compartment. And the one thing you should think about acute compartment syndrome. What can cause that are a number of things, including trauma, infection, burns, trauma to the muscles. It's very important to make the diagnosis early because depending on what the cause is, you may have to do some kind of emergency surgery. John, do you want to talk to us a little bit about acute compartment syndrome?
Well, usually it's due to edema of the muscle. And when you think of it, that's the way I was taught, is you operate on it. You don't wait for a day or two to do the surgery and do it right away. They have a way to measure the pressure in the muscles nowadays, but I'm not sure it's very accurate. So if there's any doubt, especially now that we have MRIs, you can do incisions distal and proximal and just do a fasciotomy. If it's one compartment, you just do one fasciotomy. It works pretty well.
So it's to allow the pressure to decrease so that you don't have obstruction to arterial flow and then necrosis due to occlusion of the vascular flow. And then just acute disease, you get a lot of edema. Chronic disease, you get more muscle atrophy, dense fibrosis, and calcification. But in the acute cases, it's a kind of an emergency situation where you have to relieve the pressure and the cause of the pressure to allow.
I've never had to operate on the forearm, but the most common is anterior compartment of the lower leg, and that's where I usually get kicked, like in soccer and so on. And that's the most common area for tibial fractures, etc.
Okay.
And I just released the compartment. It works pretty well. One thing you don't want to do for this condition is wait for it to go away, because it's not going to. 24, 48 hours go by and your muscles are dead. And after that, if you operate, then you leave a real ugly looking lower extremity or whatever, or forearm. It atrophies, the muscles die, and that's it.
Thanks, John.
So you have to operate on these.
Okay, Robert.
All right, so we have a 55-year-old female, swelling, pain, limited range of motion of the left shoulder. On the T2 weighted images, there's a lot of muscular edema, most of the muscles of the shoulder, maybe some sparing of that lateral deltoid and pec. On the bottom, gadolinium enhanced images, it looks like there's some peripheral enhancement and decreased enhancement of some of the musculature itself.
Okay. So a lot of edema, as we saw, kind of spotty enhancement, but in a kind of a peripheral nature, which makes you concerned that you may have necrosis of the muscles. And this is rhabdomyolysis, typical appearance. Often due to trauma, immobilization, burns, toxins. And the big thing here is that you get myoglobinemia, which can clog up the kidneys and produce renal failure.
Alcohol is a little different. That you get that from compression, and
Yeah.
Usually they damage the nerves.
As we talked,
I've never treated a alcoholic for this condition.
just remember there's a long list of other drugs that can actually have direct impact on the muscles and cause rhabdomyolysis.
Yeah.
Okay, Dan.
Okay, 57-year-old male, movable mass in the right thigh. Oh, it looks almost like T2. It's a little increased signal in the interior. At first I thought it was like another like fascial, like an avulsion, not avulsion, herniation, but with all that increased signal, especially going to the other, there we go.
Okay.
Not sure exactly.
And kind of a non-specific increased psychogenic area in the muscle.
Yeah.
And this is another type of myonecrosis. And here...
Was this a contusion, John?
It can be caused by several different things. Myonecrosis. The thing here is you get this REM enhancement. So you've got to think about, obviously in the right setting, compartment syndrome. But here you also have to worry about possible abscess. On the T1 weighted images, it can look like tumor, but the peripheral enhancement is more like an abscess. And non-enhancing center makes you very much worried about necrotic muscle fibers. But this this also could be myonecrosis from any of those conditions that we talked about before, including trauma. Okay. LER, here's a patient who had multiple fractures. We don't really see them on this particular image.
Right, 50-year-old male.
September 20th, 2011.
One thing, if I may interrupt a little bit, one thing about these conditions where your muscles is damaged is don't push the activity on a muscle. You go about activity slowly, and anti-inflammatory drugs are quite effective in their use to prevent calcification and permanent contracture. So anti-inflammatories and gentle progression of motion
Thank you, John.
to prevent calcific myositis.
Great. Okay, so here's a CT, and here's some.
Which is I'm sorry, it's quite common in the thigh, anterior thigh.
Yeah. So here LER, we can see an MR scan showing one of the many fractures in this multi-trauma patient. What about the muscles?
The right psoas, there's some intramuscular increased signal. Region of the iliacus, bilaterally.
So there are a lot of what look like fluid collections within the muscles. Here are the axial images, also showing the psoas involvement.
Mm-hmm.
And that's iliopsoas, both are involved, aren't they, John?
Yeah. And here we can see the spinae erecti muscles are involved as well.
Mm-hmm.
And a little bit of enhancement, peripheral type enhancement. Here are the axial CTs involving looking at the paraspinous muscles. Not really any flow in this on the ultrasound.
So in trauma, could these be intramuscular hematomas? Could it be rhabdo?
Yeah.
Yeah.
This is post-traumatic rhabdomyolysis, and they can be pretty severe.
Okay.
All right.
How often do you see that, John?
I've never seen a case like that, but I don't work really, as you know, in a trauma center anymore.
I never have either.
But I've, when I worked in the ER at Cedars for a number of years, I never saw it either, but.
I've worked at many different ERs and including Korea, but I never saw a case.
Yeah. Okay, Tayson.
All right, male lifter with 3 days right elbow pain after curls. So we have diffuse grease signal of the bicep and brachialis muscles. It looks like fibers look intact.
Okay.
What I see of the tendons there, yeah.
So this is another rhabdomyolysis. Now, typically what you'll get, which I think I'll show in a minute, you'll get pain in the muscles kind of a day or two after you exercise, and they can be painful for 7 to 10 days typically, which is just a delayed onset muscle soreness syndrome. But if you go beyond that, you can actually get rhabdomyolysis and destruction of some of the muscle cells due to very heavy exercise, and that's what this is, rhabdomyolysis from exercise. Robert.
All right, so we have a 52-year-old right hip pain, had a slip, alcohol drinking plus tranquilizers, elevated CK, myoglobin, creatinine. It's not good. Looking at the right gluteal musculature, there's a lot of edema and only peripheral enhancement in some regions there. So I'd be concerned for rhabdo again.
Yeah. So here we can see a lot of edema within the subcutaneous tissues and the muscles. A little worrisome here that you don't really have contrast enhancement in the bulk of these muscles. And this was rhabdomyolysis, and this patient went into acute renal failure due to the myoglobinemia. Okay, Robert?
Sure, I'll go again.
I'm sorry.
Yeah.
Dan, my error.
68-year-old male, left thigh pain for 1 day in the ER, past medical history of diabetes for a long time, cholecystectomy, colodocoduodenal fistula with pneumobilia and liver abscess. I'm assuming it's probably, there's like anterior compartment, looks like, increased signal peripherally with, fluid. I'm guessing this is probably like an anterior compartment rhabdomyolysis, drug-induced.
Yeah, this was probably rhabdomyolysis, but this is probably not drug-induced.
Oh.
This was actually a bacterial infection.
Oh. Okay.
So another reason you can get compartment syndrome and a rhabdomyolysis is actually direct infection. And this was E. coli, actually a mixed infection, probably coming from the biliary tract.
Okay, 55-year-old male with weakness. The CT, let's see, do we have atrophy in the calf muscles? Maybe.
Down here.
Yeah, atrophy in the lateral calves.
Relatively symmetric, mostly symmetric, a little bit of asymmetry. And this, so what would you think this would be?
Something congenital, like a myopathy. Yeah.
So the congenital myopathy.
Well, the patient had surgery on the back.
Yes, they did. Yeah. And this is typically, this one is usually a spontaneous mutation. And one of many that would probably be described over the years. Okay, Tayson.
All right, severe crampy muscle pain 3 days after Ironman competition. Looks like we have bilateral gastro edema.
And here you can see that a typical feathered kind of appearance that you can get in what used to be called grade 1 strains of the muscles, where the architecture is still intact, but you've got edema in between the fibers. And here, another image showing the same thing, symmetric, and now some of the other muscles are getting involved.
Yeah, some inner thigh muscles as well.
Okay,
Vastus.
so this is 3 days later. So this is typical delayed onset muscle soreness syndrome.
Okay.
And typically lasts 3 to 10 days, something in that order, depending on the severity. There's coming up. Now, the other thing that can produce muscle problems are peripheral nerve injuries. And did I do a lecture on nerves? I don't think so. I don't think, right? Did I do one? I think we talked a little bit about the architecture of nerves. Okay, I think we did. I think we defined the Selden and Sunderland type neuropraxias. So the mildest form is neuropraxia. It's grade 1. You get focal demyelation of the nerve. EMG is little blotches, but the MRI is usually negative in these, and it's usually a transient symptoms of neuropathy and muscle weakness. Axonomesis, grade 2, 3, and 4 of the Sunderland sequence. You have different disruptions of different areas, more progressive, involving the nerve structure. You stop getting conduction at the level of the abnormality. You can get transient increased T2 or stir in muscles. And you can also get enlargement of muscles, or in the nerve, you can get enlargement of the nerve with edema pattern within the nerve. And then neurontomesis, which is basically a rupture, a tear throughout the entire nerve, loss of axon continuity, no regeneration at that level, absence of conduction. And this is typically a surgical condition. You want to reposition the nerve, and then hopefully the nerve will reconstitute and grow at about 1 millimeter a day distally along the course of the nerve. Sometimes that doesn't work, and you have to do transfers of either nerves or muscles for functionality. But we're not going to talk too much about this on this lecture. Just remember that you've got these gradings of nerve injuries, and they can cause lack of sensation, but here we're mostly concerned about lack of function of the nerves, of the muscles that they innervate. So let's look at some of the common sports nerves injuries. And here, this will be the sport here, the site of the abnormality and the cause. Baseball, the common ones are suprascapular nerve, axillary quadrilateral space, and the ulnar nerve. Suprascapular is due to chronic repetitive stress, or more commonly, in my experience, these happen to do with posterior superior labral tears and a paralabral cyst, which then extends into the suprascapular fossa, compressing the nerves, either up above where it gets both the supraspinatus and infraspinatus innervation, or the spinal glenoid notch where it just gets the infraspinatus. Then you can direct trauma, you can have to the quadrilateral space, affecting the axillary nerve, which can then affect the teres minor muscle. And then you can get ulnar nerve compression at the level of the cubital tunnel, primarily in baseball pitchers. And then there's cycling injuries, the ulnar nerve, the median nerve, and the pudendal nerve. Ulnar nerve compression at Guillaume's canal from holding on to the handlebars. Compression of the wrist you can also get from the median nerve, and then from the seat you can get compression of the pudendal nerve. Running, you can get interdigital neuromas. It's thought to be during the stretch from the push-off in runners. You can also get these in women who wear high-heeled shoes, where you also get the same stretching due to hyperextension of the metatarsophalangeal joints. And then running, you can also get the tibial nerve due to compression at the ankle. And runners, you can also get jogger's foot from compression of the plantar nerve. And football, you commonly can get stingers. I think we had a whole lecture from Kerlin Job about the cause of stingers and what to look for in the treatment of stingers. And a lot of this has to do with the length of time the patient's symptomatic. The longer the time, the more likely you're dealing with a significant problem that requires hospitalization and an MR scan to evaluate. Skiing, you can get the femoral nerve due to compression from approximately from the flexors and distally from the boot compression, and then also the ulnar nerve from compression at the wrist from the poles. Tennis, you can get radial nerve compression during serving, suprascapular again during compression during serving, but you can also get superior labral tears and paralabral cysts like in baseball. And then weightlifting, you can get medial pectoral involvement, intrinsic compression from hypertrophy of the muscles. And then in nerve injuries, if you can have severe injuries with transection that require, where you get complete disruption of the nerve that requires surgery. Less severe, you get the more the neuropraxias, where a lot of these, if they're minor, rest is involved. If it doesn't work, then you have to go into the surgery. And these should all really be evaluated by neurologic and neurosurgical specialists. Okay, I don't remember who was last. Okay, Elior.
So history withheld. This radiograph. Yeah, it looks like deformities of the hip joints, dysplasia of the hips, under coverage of the acetabulum.
It's here.
Oh,
So,
okay.
let me just show you the elbow.
Right, this calcification along the anterior elbow.
It's really ossification through the very end, right?
Mhm.
All these ossicles, soft tissues.
Yeah, just again, kind of everywhere. These ossifications in the muscles.
These deformities, right? So this is called Stoneman syndrome. Have you ever heard of it?
I think so.
The patients actually become stiff, as you can see. Why? Because of all this. This is due to a autosomal dominant change on chromosome 2q. It's generally a spontaneous mutation because these people tend not to procreate children. It's quite rare. All right, any questions about muscles? All right, well, thanks everyone.
Thank you.
Thank you.
Thank you.